precentral gyrus, just in front of the central sulcus. We had talked previously about this being called M1, standing for the primary motor cortex. And we also talked about another area that was just rostral to M1, but more dorsal, and that's going to be your supplementary motor area. And then just ventral to the supplementary motor area, still rostral to M1. Is that coming up as a, that's orange. That's going to be your premotor cortex, or PMC. Okay, so just a quick review, and remember that M1 is your primary motor cortex, and your SMA and your PMC are going to be involved in motor planning. Okay, motor planning. They're big on motor planning. Something we've seen previously that we're going to talk about plays a role today in the communication of the basal ganglia with the primary motor area is going to be the thalamus. Okay, so here's your thalamus. And that's something we've seen before. And introducing for the very first time today, the new player on the field is this group of structures known as the basal ganglia. And I'm just going to abbreviate basal ganglia as BG. We're going to take a look here at what all the basal ganglia, what all comprises the basal ganglia. But for right now, we'll just represent them as a big BG. So what we're going to see today is that for motor planning, it's really important that the premotor cortex as well as the supplementary motor area communicate with the basal ganglia. So they're going to say they're thinking about moving, so they're going to consult with the basal ganglia. Basal ganglia is going to look at the situation, and we'll talk about some two different pathways today, both the direct and the indirect pathway. And it's going to send that pathway information to the thalamus. Okay, and that thalamus is going to communicate that information back to the motor cortex. Okay, if all is well, then the SMA and PMC communicate with M1. Here we have, there's neuronal cell body. They're located in the primary motor cortex. And if movement is okay, then send down through the corticospinal tract, and you get voluntary skeletal muscle contraction. So nothing really new there. We're just going to talk about the basal ganglia, but they play a really important role in modulating motor output. As far as functions of the basal ganglia are concerned, there's going to be three that you need to be aware of. I'll write those out here. So functions. What do these things do? Does anybody know what basal ganglia is involved with? Any thoughts? Coordination? No, not coordination. So, particularly when I think about Parkinson's patients or patients diagnosed with Parkinson's disease, the one big one is going to be initiation of movement. Okay, initiation of movement is going to be huge. Patients with Parkinson's disease really have trouble getting started. They can actually get stuck. Yes?
Oh.
It's
Does
okay.
it have any, like, proprioceptive factors in it, in the sense of, they're making a movement and they think that they're doing, say, like, a full movement, but they're really only moving a little bit, into that range of motion? Or is that all,
That's all the job of the basal ganglia.
that's all it is?
That's all included too, and that's going to be another function that we're going to look at. Basal ganglia are involved in modulation of movement amplitude. Okay, we'll get there in a minute. But yeah, the basal ganglia, everything with a Parkinson's patient is going to be small, hypo. Yes? Anything. So initiation of movement. I want to walk. Ready? Here I go.
Oh, you just don't move.
No, they move. It's just going to take them a while to get there. Everything's going to be really slow, and then I want to go. I really want to go, but I have trouble. Initiation, starting the movement. They have trouble. It might take them 30 minutes to walk from here to that end of the room. Just their movements are very slow, and this has to do with the modulation of movements. But their ability to start and stop. So, especially when it comes to turning, oh my gosh, you have them go and then they want to turn around. Very hard for them to initiate the turn. Very hard for them to initiate sit to stand or stand to sit. That's another place where they have difficulty. But starting any movement is going to be very difficult for them. Okay, so so that's going to be initiation of movement. That's going to be very prominent in Parkinson's disease, and that's going to involve what we're going to talk about today. It's called the direct pathway or the GO pathway. We're gonna draw this out. Okay, the direct pathway, basal ganglia. Direct pathway. If you want to think GO, that's the best way to do it. Okay, I can put this down as the second, and that's going to be. Logan was talking about things being really small. Right? All the Parkinson's movements are really small. There's actually therapy called big therapy. You get them to move bigger than they think is appropriate, and that would be their normal. Okay, they talk very softly. Bradyphrenia. I mean, there's all kinds of problems, and that's going to be the second. Here is going to be modulation of the amplitude of movement. So the size. How big Parkinson's patients think they're moving normally, or speaking normally, or thinking normally, and it's actually very slow or very small. And then the third function of the basal ganglia is going to be to inhibit unwanted movement. Okay. Example of a disease process that is classic for this would be Huntington's disease. So Parkinson's is initiation, but inhibition of unwanted movement is going to be Huntington's disease. Okay, and that's going to involve something known as the indirect pathway that we're going to talk about today. And that's going to be stopping unwanted movement. Okay, questions about that? So this is my big overview picture. Okay, just starting, thinking about what the basal ganglia do and who are the players involved in basal ganglia function. Ian?
What does it say, indirect?
Pathway. Yeah, indirect pathway versus direct pathway. Indirect pathway would be the stop pathway, stopping unwanted movement. Okay, Huntington's disease is going to be something that you see. Okay, let's move on. Let's look at what structures are actually comprise the basal ganglia. Not shown here. this is my standard frontal section right through the cortex. So here's the left and right half of the cortex. And moving on down here, this is going to be a transverse section through the brainstem, okay, specifically in the midbrain. And you're looking at this nice marker here. This is my cerebral aqueduct right there in the middle. Okay. So you know you're in the brainstem when you label that. It's not part of the basal ganglia. So no. Okay, looking at this. Things that look familiar to us. Hopefully you've come to recognize this is the thalamus. Okay, and we've seen these structures before. I've drawn them up, but I said we'll talk about them when we get to the basal ganglia portion of the course. Well, here we are. Let's go ahead and start labeling some of these guys. This one right here is going to be just underneath the lateral ventricle. So if you can imagine the third ventricle lying here between the thalami, and then that lateral ventricle coming out, the caudate, this is the caudate nucleus, lies just underneath the lateral ventricles. So that's caudate, C-A-U-D-A-T-E, nucleus. Okay. And oftentimes the caudate works in combination with another one of these structures. And this structure here is if you look at this, it looks kind of like a piece of pie bilaterally, right? The most external region here is known as the putamen. Like I said, the caudate and the putamen often work together. We'll see that a little bit today. Okay, so this is your putamen, P-U-T-A-M-E-N. Okay, everybody's present bilaterally. And since the caudate and putamen often work together, they can be referred to collectively as the striatum, S-T-R-I-A-T-U-M. So that's just you hear the word striatum or you read the word striatum anywhere, that just means that it's the combination of the caudate and the putamen working together. We'll see that a little bit today when we look at nigrostriatal. Okay. Now, the innermost part here bilaterally, let's take the one that's closest to the putamen, label that. That's going to be something known as your globus pallidus externus. Okay. So your globus pallidus externus is here. So Globus Pallidus, and that's externus. It's externus. You can remember that because it's closest to the outside, external. And in addition to the globus pallidus externus, there's also a globus pallidus internus. And that's the innermost piece here. Okay, so that's your globus pallidus internus. And, collectively, so you have globus pallidus externus and globus pallidus internus. And on the outside of the piece of pie, there's the putamen. So all three of these together you may see called something known as the lentiform nucleus. So lentiform nucleus is nothing more than the combination of putamen, FORM, nucleus. Lentiform nucleus is just the putamen plus the globus pallidus internus. Yes, Hannah?
What was that last one again?
The lentiform, Lentiform nucleus. Probably the easiest one to remember is this pair of structures here that sit under the thalamus. These structures are going to be working in something known as the indirect pathway. And I think they're easy to remember because they're simply called the subthalamic nuclei. Subthalamic under the thalamus. One is going to be a subthalamic nucleus, but there's a pair. Okay, so just these guys here sitting under the thalamus, they're your subthalamic nuclei. And then there's one more area that's going to be particularly important in Parkinson's disease. And this is the area that makes dopamine in the brain, or the majority of it. This is an area in the midbrain. It's the only part of the basal ganglia not located in the cortical region. And this is known as substantia nigra, or substance black, black substance. Because it's actually black in color. When we go through and do some transverse sections of the midbrain, you can actually see the substantia nigra. It's like this black color. It's two nice rows. And one year we had a patient, actually the same year, we had a patient that had Parkinson's and a patient that had Huntington's, as well as normal bodies, and we could actually look through the midbrain, see the lack of the substantia nigra in the patients with Parkinson's, and see the lack of the caudate nucleus in the patients with Huntington's. It's kind of cool. Do you guys, the bodies this year don't have any? No, not lucky this year, but okay. And that's it. Those are all the players that we're going to talk about today that comprise the basal ganglia. Questions? Good? All right, let's move on. So this is a lot of new words, right? And a lot of neuroscience has been words so far, so nothing new there. A lot of new words. And this is going to be your neurotransmitters, receptors, and action potential. What I'm doing here is these structures are just my representation of a basic neuron. Okay, all these are basic neurons. So this is going to be presynaptic neuron, and this is going to be your postsynaptic neuron. Everybody got that? So this side's presynaptic, and here's the synapse, and then here's your postsynaptic. And your postsynaptic neuron, if you remember, is the one with the receptor, okay, specific for the neurotransmitter. So for the rest of the talk, I'm going to keep my colors very consistent, and when you see a neuron that's labeled in a red color, that means that that neuron releases glutamate. Anybody remember, is glutamate excitatory or inhibitory? Excitatory, yes, good. So red color is a glutamate releasing neuron. Okay, I may say, so I can say glutamate releasing neuron, or I can just say glutamatergic. That just means it releases glutamate. All the same. Okay, so all the red colored neurons that we're going to draw today in the pathways are going to be releasing glutamate. That means when the action potential goes down and calcium floods in, there's going to be a release of glutamate into the synaptic cleft. All right, so that's going to be my glutamate. And that glutamate is going to make its way to its specific receptor, so it's a receptor for glutamate, the neurotransmitter. And when the neurotransmitter binds to the receptor, what's going to happen to that neuron? Is it going to depolarize or hyperpolarize? Depolarize, great. So you're going to have an influx of sodium, right? So glutamate's going to cause an influx of sodium into the cell, and that influx of sodium is going to make the cell more positively charged, and you're going to get a depolarization. And that depolarization results in the action potential going down the neuron. Right? Nothing new, something we've seen before. Okay, red, glutamatergic neuron. Keep it consistent. And now blue. When I use blue to color a neuron, it's going to be a GABA releasing neuron. Is GABA excitatory or inhibitory? Absolutely. That's a GABA releasing neuron. Okay, so you can imagine this neuron releases GABA into the synaptic cleft. There's my GABA. That GABA is going to make its way over to the postsynaptic neuronal receptor for GABA. Okay, when GABA binds to the postsynaptic neuronal receptor, what happens to that neuron? Hyperpolarization, correct. So what we have is potassium is leaving the cell to make it more negative. And that's going to result in hyperpolarization. Hyperpolarization, that particular neuron is not going to be releasing its neurotransmitter. Right? That's what that means. And we have one last neuronal cell body down here, and I'm going to choose to make this one gray in color. And that one's going to be a dopamine releasing neuron. Dopamine releasing neurons are, the cell receptors are a little different. Dopamine releasing neurons are all the same. So this is a dopamine. Dopamine releasing neuron. That means it's going to release dopamine into the synaptic cleft. Dopamine releasing neurons are all the same, but the kinds of receptors on the postsynaptic neurons are different. Let's say this particular receptor is known as a D1 receptor. If dopamine binds to the D1 receptor, this results in neuronal depolarization. So sodium is going to flood into the cell, and that neuron is going to depolarize. Okay. Let's go to fire. And sometimes the receptor can be something known as a D2 receptor. if dopamine binds to a D2 receptor, that results in hyperpolarization of that particular neuron. So the potassium's leaving the cell, and that cell is now, that neuron is now hyperpolarized. Okay, I break it down, trying to make it really simple to understand, because this is going to be really important for understanding the different pathways we're going to talk about. Okay, there's two different pathways, the direct and the indirect pathways. But you need to understand this concept. And when I go through the pathways, don't try and think about what's causing the neuron to fire or anything like that. What you're going to look at is changes in the concentration of each of these individual, whether it's going to be glutamate, GABA, or dopamine, into the postsynaptic cleft, and you're thinking about the change in concentration of those neurotransmitters at that time in response to what's happening at the level of the brain. Okay, questions about that? All right, let's see if we can give it a go. This is where the direct pathway is pretty straightforward and pretty easy. If you think about direct pathway, you can consider it the GO pathway. Okay, this is the one that's going to be involved in the initiation of movement. Okay, and all I've done here is I've taken just half of the cortex. You know, so here's my thalamus, here's my subthalamic nucleus, caudate, putamen, globus pallidus externus, and internus. I'll start labeling. Bless you. Subthalamic nucleus. Okay, here's my. We're not gonna put in the substantia nigra quite yet. That's gonna be next, but this is my substantia nigra in the midbrain. Okay, so globus pallidus internus, I'm gonna abbreviate that as GPI. Globus pallidus externus, that's gonna be my GPE. Right, and then this is my putamen. There's my caudate. Okay, so we're just looking at half of what we were looking at before. We're looking at the direct pathway. Okay. This is the direct pathway without any dopamine added. We're just going to start from square one. Thinking about, here is, just think about the combination of the SMA, PMC, and primary motor cortex as the, we're going to just make that the motor cortex. See where we are? Okay, so the motor planning area is considering moving. So there's a question mark. Is it okay to move, or should I move, or am I ready to move? Is everything okay to move? And before you move, you got to consult with your basal ganglia. And specifically, we're going to be having neuronal cell body here that sends out axons to both the caudate and the putamen. Remember, they're collectively the striatum. So thinking about moving, neuronal cell body in the motor cortex sends out axons to both the caudate and the putamen, and the caudate and putamen then send out, so the neuronal cell body here in the caudate, and there's also a neuronal cell body here in the putamen. Those neuronal cell bodies then send out axons to synapse with a neuronal cell body that's located in the globus pallidus internus. Okay. Now, globus pallidus internus neuronal cell body sends out axons that connect up with the neuronal cell body in the thalamus. You don't have to know any particular part of the thalamus. It's just a neuronal cell body in the thalamus. And that neuronal cell body then sends out the collected information about movement back to motor cortex. Okay, looks pretty straightforward, right? All right, let's go through and start labeling some stuff. So, this is a red neuron. So, it releases what into the synaptic cleft? Glutamate. Okay, so you're going to have a increase in glutamate here. You're going to have lots of glutamate being released here and also here. So increase in glutamate. Okay. If you release glutamate into the synaptic cleft, what happens to the neurons that it synapses with? Causes them to fire. You're going to get a depolarization. The next neuron in sequence is a GABAergic neuron. It's going to release GABA, right? So you're causing the release of GABA here. Okay? If you cause the release of GABA with a the next neuron that's postsynaptic, if there's GABA present, what happens to the next neuron in sequence? Is it going to release GABA or no? No. So you're going to have less GABA here. Okay, and then if there's the concentration of GABA here has been decreased, is this neuron going to fire or not fire? Fires, correct. So what you get overall with the basic direct pathway, no dopamine involved yet, this is just going to increase movement. That's why it's called the GO pathway. Okay, so the GO pathway is set up just like standard. This is just all the players of basal ganglia without the addition of dopamine yet. Dopamine's going to add another level. The GO pathway, or the direct pathway, results in an increase in movement. Okay? So realize that this isn't the normal physiological situation ordinarily. The neurophysiological situation would have the inclusion of dopamine in a normal, healthy individual. Okay, questions about that? Yes, Ian.
Can you explain again why GABA is decreasing in the thalamus?
So specifically GABA, if you have more GABA being released here, that's causing this neuron to hyperpolarize. That's going to decrease the concentration of GABA at this synapse. If there's less GABA, that releases this neuron from inhibition, which causes it to fire. So that's like I said, so you have to think about the relative concentrations and the changes with each of these things. Neil, did you have another question?
So why does hyperpolarization increase the concentration?
If if it weren't, if the system weren't activated, there would ordinarily be more GABA at that position. But since the system was activated, you get less GABA because of the release of GABA here. It's all about the amount of GABA at this position. Okay? And there's more GABA at this position because it was caused to fire by the motor cortex glutamatergic neuron. Does that make sense? Okay, I need to, do you see? Is anybody else having trouble with that? This is where people sometimes get lost, so I'm just trying to check one step at a time. This isn't normal physiology. This is just the GO pathway by itself without the influence of dopamine. Okay, hold on. Yes?
So, is that, so are the blue ones the,
GABAergic.
those are the GABA releasing neurons, and the red ones are the glutamate releasing?
Yes.
Okay.
Does that make sense now? Okay.
Yes.
Yes, got to put it all together. We haven't touched dopamine yet. We're just looking at the blue versus the red in the GO pathway. LA, did you have another question? So, LA wants me to run through it one more time, and let's look at it from the beginning. Okay, motor cortex, thinking about moving. There's a neuronal cell body here that's red. That means it's a glutamatergic neuron, or a neuron that releases glutamate. Okay, that neuron is depolarized because you're thinking about moving, so you have an increase of glutamate in the synaptic cleft here in both the caudate and the putamen. If you have glutamate released here, what happens to the next neuron in sequence?
It's excited.
Yeah, it's depolarized. Since it's depolarized and there's an action potential, you get the release of GABA at this space
Because they released.
because they've been depolarized. This depolarized causing the release of GABA at this space. Now, if there's release of GABA here, this neuron hyperpolarizes, which results in less GABA at this space. If there's a decrease in GABA, that allows this to fire. And just think about relative concentrations. Does that make sense now? So just talking about the red and the glutamatergic, GABAergic neurons. Nothing else. Okay, everybody else doing okay? Any other questions? Okay, GO pathway. Let's move on to adding dopamine. So here, when you talk about dopamine, in addition to the GO pathway, you're talking about the nigro, which is substantia nigra, striatal, which is caudate and putamen, right? Striatum. Okay, so here we're looking the nigrostriatal pathway specifically for the direct or the GO pathway. Okay, so the only thing that's going to be different now, I'll just go through and label all the pieces again. So we have our substantia nigra down here. Got our subthalamic nucleus. Here's your thalamus, caudate, putamen, and then your GPE and GPI. Closed palace internus and closed palace externus. So just labeling all the players. And think about up top here, we still have the motor cortex. And again, we're going to be thinking about moving. So let's just draw. Let's just draw the GO pathway in there again without the influence of dopamine. So there's a neural cell body here in the motor cortex. Sends out axons to the caudate and the putamen. And just your basic GO pathway. And those axon synapse with a neuronal cell body in the caudate and the putamen. Send out axons to neuronal cell body synapse within the GPI. Okay, neuronal cell body from the GPI sends out axon synapse in the thalamus. The glutamatergic neuron that synapses back with the motor cortex. Nothing different than what we just drew, exactly the same. Now, we also have to consider the influence of dopamine. And I can tell you the dopamine is released here from the substantia nigra. So there are neuronal cell bodies here in the substantia nigra that send out axons to both the putamen and the caudate. Think about how to, let's do it this way. So these are dopamine releasing, so I'll just put that. Okay, so dopamine releasing neurons send out axons that synapse with the same neuronal cell bodies in the caudate and the putamen. And what do you want to know about these postsynaptic neuronal cell bodies in the caudate and the putamen? Yeah, is it D1 or D2? Okay, and I'll tell you that both of these have D1 receptors. Okay, so if they have D1 receptors, is that going to lead to depolarization or hyperpolarization of the next neuron sequence? Depolarization. Great. Okay, everybody see where we are? What happened? Okay, let's go ahead and fill it in then. So here you have the release of glutamate as well as the stimulatory effect of the dopamine is additive here and here. So you're getting an even stronger influence toward depolarization. So you're really firing. So you're going to release even more GABA at this point. Okay, so you think about dopamine being synergistic with the glutamate, okay, because of the presence of the D1 receptors. All right. So, which causes a whole bunch of GABA to be released here. If there's a whole bunch of GABA being released here, this is going to be hyperpolarized, and you're going to have a whole lot less GABA being released here. If there's even less GABA at this position, that means that this neuron is released from inhibition completely, and you're really going to increase movement. So in the presence of dopamine, let's say you get normal movement. Okay? And that normal movement is synergistic with, and it happens because it's synergistic with the glutamate that's already being released by the neuronal cell bodies from the motor cortex. Yes, Alex?
Could you give an example of what would cause just a go pathway to fire versus direct go?
Okay. So yeah. So you're leading me into exactly where I want to go. You're a plant, perfect. An example of when you would just see the go pathway is Parkinson's, right? Does that make sense to everybody? They don't have the dopamine coming in. So that's what you see, that lack of initiation. Yeah, that's perfect. Great question. Yeah, absolutely.
They don't have the dopamine coming in, or the dopamine coming in is getting, basically by the lack of
The dopamine, Parkinson's patients actually don't have substantia nigra. They have no dopamine releasing neurons. They die over time. You can supplement dopamine to a patient with Parkinson's and help improve their movement, right? There's a medication, it's called Cinnamon. You'll know more about it next year too. Okay, so you can supplement with exogenous dopamine, which acts as an agonist. That works great. Okay, but if you have Parkinson's, you lose your substantia nigra, which causes the dopamine. There is no dopamine. That's the problem. It's lack of dopamine. And that is just the direct pathway without anything else. Okay, other questions? Does that make sense? Hopefully it'll make sense. It gets a little confusing, but when you work through it, which we will, you'll get it. Okay, let's go ahead and take a 10-minute break.